Welcome to 2023, our STED Talk, Spine Technology Education. Discussion, discovery, discourse are the topics of these sessions, and I welcome all of you from around the world. My name is Jens Chapman, and again, today is January 18, 2023. Today we have a great speaker, not from the spine world, but in a crossover capacity. Dr. William Cross, known affectionately as Woody, is going to speak to us from the Mayo Clinic. And I'm going to address him and introduce him more formally later. I don't know whether he's live yet. He's actually doing a case right now in Rochester, Minnesota. But he comes to us from the perspective of a trauma surgeon who was originally involved in sacroiliac fixation, has some different ideas and some similar ideas to spine surgeons. And he's going to educate us a little bit more about the aspects of trauma and modern fixation for sacroiliac fixation, with some criticisms and some enhancement thoughts. So we're really looking forward to having Dr. Woody Cross speak to us later. Angela, Ben, good morning. Is he live with us right now? Not yet. So again, in and out of a trauma case, we're curious what it is. But as always, we have 4 cases to introduce, and it's a particular pleasure to introduce some of our colleagues from Tacoma who took the long trip up the road, Dr. Martin Covey, and I'm sorry I forgot you, Sarah. And Sarah came all the way up from Tacoma, so it's really cool to have you here. There's a little snippet of you, and we'll call upon you for your commentaries on these cases. The 4 cases were selected specifically under the aspect of lumbopelvic problems, and we'll be excited to hear your thoughts on that also. And I'm going to monitor the chat room, so without much further ado, we'll start with a simple one, and as Dr. Jared Cook, who just last night operated with me. So Dr. Cook, take the lead.
All right, let's get this going. So I'm Jared Cook. I'm one of the orthopedic spine fellows here. So let's start off with this case. We have a 62-year-old female comes in with mid-low back pain, right lower extremity pain, forward-leaning posture. She's got about a 5-minute walking and standing tolerance. Past medical history is RA, obesity, osteoporosis. Has had 5 prior lumbar surgeries, starting with a remote discectomy. There were fusions at L3-4 and L5-S1 T-lifts, and subsequently got an infection, epidural abscess, had a Lamison evacuation of that, and then later on ended up getting a spinal cord stimulator. So came in with a DEXA, T-score is negative 1.5. So really on her neuro exam, really just loss of lower extremity reflexes, EHL is at 4s. And so because of that remote history of infection and suspicion for possible non-union, did get ESR and CRP, which were within normal limits. So this is what we see on presentation with her X-rays. So she is quite flat. Her lumbar lordosis is about 14 degrees, and thoracic kyphosis is about 18. And so you can see the stimulator there. You see the skip level fusions. One thing I really want to point out is when you look at those T-lifts, see the rods, they've not been contoured. They're just completely straight rods, and she has focal kyphosis in those areas, which you can see better on the CT scan. So that 3-4 has healed. It's healed into kyphosis, and then at 5-1 there is some suspicion for non-union. It actually did heal in the posterolateral aspect of it, not through the disc space. And then we have select cuts from L1-2 and L2-3, where she's got stenosis, chronic compression fractures at T12 and L1 as well. And so overall, her global picture is just very flat. Bone scan and SPECT shows, there is some constant remodeling in that compression fracture area. Otherwise, a little bit down at L5-S1 and SI joints. So overall assessment, flattened lumbar lordosis, chronic junctional compression fracture T12 and L1, acquired kyphosis, mostly at L3-4, but she does have solid fusions there at 3-4 and 5-1. So at this point, what would our audience do?
Do you mind going back? That's a very nice summary, Jared. Would have been nice to put the overview shot there. Go back to the scoliosis film. So again, very nice summary. No, go forward. Yeah. So there's no neurologic catastrophe. There's no postural catastrophe. And I'll go to our friends, Dr. Martin, maybe. So there's nothing pending. There's just a summary of like 5, 6 different procedures that were all done more or less in an outpatient environment beforehand. And now we have kind of just a messy situation. The patient actually can't walk straight. She's actually very well rehabilitated. Is she on opiates? Is she opiate dependent or?
Yeah, but like low dose Norco.
Yeah. So she's done a reasonable job maintaining things. She has a intact social setting, a hardworking husband. She's no abuse history or anything like that. So first of all, maybe who wants to take the microphone first? Dr. Covey, Dr. Martin? What do we think about this kind of a trend that at least we see in our clinic a lot of a summary of small little, quote, quick fixes that are usually accompanied by the sense of we don't know whether this will work or not, but we might as well just try something. And then we have kind of just a messy picture in front of us. Is this something you see also? Is this selective for us?
Yes, I think, I mean, sometimes it's hard to say. Of course, if somebody has these surgeries over a time frame of 30 years, you could say, okay, but to have intermittent short fusions and lammies in between, that's sort of a prescription for requiring additional surgery. Overall, her sagittal balance looks good. I'm not sure what it measures out to be, but
-1.
yeah, so. So that's
encouraging. Yeah, she has junctional compression fractures. She doesn't walk like this, but she's actually rehabilitated. So we followed her, I think, for a year with, I think, prone exercise regimens, etc.
Yeah.
So she is miserable, and again, over the course of a year, has not really improved. So do we just follow this patient along, say carry on?
Well, I guess her spinal cord stimulator isn't working.
Not to her satisfaction.
Again, another trend question. We see a lot of spinal cord stimulation. We have one of our interventional colleagues here, and I think that they've been a godsend for certain conditions, but am I the only one who sees them crassly overused?
Yeah.
No, Dr. Martin's shaking his head no.
Well, I think, to answer that question, I think, in my opinion, they probably are overused in an attempt to help folks. By the time you get to that point, they've usually exhausted pretty much everything else, and sometimes choose not to have the big whack. Well, my question is on these, and what I wonder about as I'm assessing these patients. She's a patient who's got a bad spine, and I don't know that these are ultimately fixable. I mean, forever. I think this is like treating diabetes and treating hypertension. There are things that we can do surgically as part of a treatment plan, but I tell these patients that your back is bad, and it's always going to be bad, and you're going to need a number of surgeries probably on your back once you start. And I haven't seen, to my personal satisfaction, what the best course of action is. Is it better to do a number of smaller operations first before you end up with, a T-spine to the pelvis fusion? Or is it better to do the big fusion all at one time, lock up their lumbar spine, and rely on the hips and the glutes and the legs for torso balance? And I don't know what the answer is. Clearly, I think this lady needs an operation because she's got a flat back. She's symptomatic from it, and it will help. But at age 60, she's probably metabolically and physiologically able to tolerate it. So my question, you guys do more of these. What percentage of these folks who end up with the long, T-spine to pelvis fusions, how long does it last? What percentage of them end up, do you march up the spine? And, that's some patients just don't want the big surgery, which is, I think, why they choose the stimulators. So I guess I haven't really answered any questions, but just posed some more in my thoughts on the subject.
I so appreciate that, because I don't pretend to have the final answer either. We try to, obviously, when there's no structural or neurologic crisis, try to do anything possible to treat these patients non-surgically and optimize their well-being. So we institute our rehab program that we call prehab, with everything involved: opiates, cardiovascular fitness, metabolic fitness, toxin reduction, body weight optimization, etc. Lifestyle accommodations to pivot towards a more active, engaged lifestyle. Supplemental things like a lumbar corset to be worn for activities, either an upright walk or preferably trekking poles that are nice and tall, prone exercises, swimming, etc. So yeah. Rod, any thoughts? So this is not a structural crisis that's acute. There's no major imbalance when we see her standing with her arms on a pedestal. She's holding an outrigger there. She walks forward pitched. She's been with us now for a year. Assume that she's, again, unusually well settled psychosocially. So she has a very good family support system. She's a very engaging person, so she's not lost somehow, and she's genuinely frustrated. Do we pull the big one, like what Dr. Martin said, or do we kind of just look at little things? Is there a role for instance, a vertebroplasty? As we know, one of her presenting complaints is lumbopelvic pain. If you go forward to the bone scan, toggle over to that, she doesn't have brutally dark spots. She has this junctional collapse that's kind of percolating along. Is there maybe a role for something less invasive, like cementing that? Is there a role for a percutaneous SI fusion, which could be added to the armamentarium of less invasive surgeries?
Yeah, I mean, I think these are always challenging cases. I think sitting and waiting is probably the way to go. That's what I would recommend. She's not. It doesn't sound like has any gross neurologic issues, right? She's not.
Just the EHL deficits.
Yeah.
That's it.
I mean, I probably would get an EMG and, treat her for, make sure you're getting, if she has osteoporosis. Her T-score was what again?
Well, so her T-score is negative 1.5, but she's got 2 vertebral compression fractures. So by definition, she's got osteoporosis. Yeah.
So, I mean, I think I would treat her and then try to, kick the can down the road. Because I think, it's the complication rates of having a T10 of pelvis are not insignificant, right? So
we kick the can for a year, and she faithfully comes back and is not frustrated by the layers of non-operative prehab measures that we imposed on her. And again, on the psychosocial background, that's the 5th dimension, she scores high. So do you keep kicking the can down the road?
Scores high in a bad way?
In a good way. No, she's very well situated.
Let's see the, do you got a CT myelogram again?
She's moderate stenosis, nothing horrible. I mean, she's compensating.
What does 4-5 look like?
It was unknown. It kind of had collapsed, but it kind of looked fibrously ankylosed. It's not hot on the bone scan.
And the canal at 4-5 looked fine. That's why I didn't bother putting a cut on.
These are difficult cases. I still would try to kick the can down the road because, I mean, my clinic is full of these cases, so it's hard not knowing the patient. I think once you're engaged with them over a year, it's much easier to make that decision. I'm not sure the spinal cord stimulator is doing anything.
It was a disappointment for the patient. Again, this is structural pain. I don't want to put our Dr. Dixon on the spot there. Why don't you go forward and say what we did? So I did not take this lightly, and I take responsibility for what happened. But we decided to go high and low and formally fuse her pelvis also. Go for it.
All right. So, made sure to optimize their bone health. So hardware removal from those 2 TLF levels, take out the stimulator, and then posterior fusion, decompression, T4 to pelvis. And, that's the, kind of correction we get. We have the hooks at the top, quad rod construct. And then there's our comparison from, being completely flat to, to her correction, came out to be about 45.
And you have a standing film now. She was in clinic just the other day. There's some standing new X-rays. Is that?
The viewer failed every time I tried to open it, so I actually
That's
couldn't.
disappointing. So
I know, I wanted them.
There's some very nice recent standing X-rays, which actually look very nicely balanced. So how's she doing? What did you see in the last clinic entry?
She's doing well. She's she's going through the rehab process. Not having the claudication symptoms, and she's rehabbing well.
Yeah. So I'm sorry that we don't have the standing films. Not sure why that didn't open up, but yeah, she's reasonably balanced. So this was a big surgery. She was in the hospital for a week or so and went to rehab for 2 weeks afterwards.
Yeah.
Did you look at her pain scores? We have them embedded. Did you do it before and after that?
I was looking through them. I mean, her ODIs are pretty high, initially, but they've come down. I want to say they're in like the 30s or 40s.
Yeah, so she's not normal, but she has, like, from my memory, an overall ODI decrease of like 25 or so. So this is not a cure. So is this worth the effort? She had no surgical complications, but I quote patients a 50% plus complication rate. I still use a product that we created at UW Times, which is free. It's called Spine Sage. And I show patients visually the complication rates. It's, I think, 15 or 17 variables that we constructed. It's over 10 years old now. Might have to be updated, but is this worth it? I mean, so far she's like 4 or 5 months out now. Dr. Martin, you shake your head. Sadly, again, the upright X-ray, which exists, I swear, looks very nicely balanced. We went high because of her osteopenia and her tendency to fall forwards when she walks.
It sounds like a success. That I think that's what makes this even harder, because here you have this lady with this enormous operation. She sailed through it without any problems, and she's better.
Yeah.
So I mean, it's kind of like golf, right? Most of us are really shitty golfers, but you hit enough good shots. You need 1 or 2 good shots around to keep you coming back. So I'd be curious to see how she does in the long run. But I can't disagree with your decision making and your decision to operate, because once you get to know a patient, and we have to make these decisions based on our clinical judgment as well. There's a gut feeling that you get from taking care of your patients, and even if it's hard or it may be risky, operating is sometimes the right thing to do. And like I said, it's a great result.
So far, so good. We did, and this is one more question, so I'll keep you on the microphone. So we did fuse her SI joints, and you didn't put CT scans on that. We actually do an open SI joint fusion and put lumbopelvic screws in there, so we use long iliac screws. When we do a long corrective surgery, is it necessary to do this? Again, one of the focal points of pain for this patient was clearly the lumbosacral junction. And we decided to formally fuse this. So I do what I was taught by our good friend, Dr. Bob McGuire, formerly of Jackson, Mississippi. He's just recently retired. But he demonstrated an open fusion where you just drill out the joints from the back, put a local more-sized bone graft, and then tap fibular allograft struts in there. He cuts them to size and then literally tamps them in. We usually put 3 in on each side. We use some off-label BMP, but how important is that we have either a SI joint fusion and or long pelvic fixation when she actually already had a 5-1 fusion? Could we just try to do a deformity reduction and tack on to the old L5S1 fusion, or in this setting, do we have to have a pelvic anchor?
I've seen enough of the failures for those long constructs. I think that the fusion and the long bolts in the pelvis are important as an anchor for that long construct in her entire torso.
What do you do for SI joint fusions? Do you just rely on the hardware, or do you fuse it formally, like since you're there already, drill it out?
I don't do a lot of these, so I haven't had to formally fuse the SI joints, but as the discussions that we've had up here over the last year or so, we'll certainly consider it for a long construct in the future.
Rod, any thoughts? I mean, so this is a big investment of time, resources, hope, sweat. pain. Is this worth it?
You know, that's a great question. I don't think we truly know the answer. So I think if you're going to do a surgery, though, I don't think, again, that's why I was my view on this is that, if you exhaust everything, you either have to do something larger or do nothing. That's why I was a little reluctant to kind of jump in, but I think you followed her long enough, and it sounds like she kind of tried everything. So
yeah, so far so good. Jared, any concluding thoughts from your end? This is a nice picture assembly.
And well, I mean, a couple of things. One, so I mean, I know we don't have the the standing films, but I mean, we have a lot of hardware reinforcing this. So I think it's a decent representation of kind of where she is as far as the correction goes. So when a patient comes to you and they have these long-standing problems, they've tried everything else, you've tried everything conservative, and you make the decision together to go through with something like this, like that's that sounds to me like a motivated patient, someone who's motivated to get better. And so seeing somebody who's just a few months out with already improvement while she's in the midst of the huge recovery from this, I mean, I think that's already speaking to to a great result. So it's kind of take that patient plus good application of technical skills, and they can do really well. And we've seen it time and again. But the motivated patient, I think, is a huge factor.
Yeah, well said.
Can I
All right.
ask briefly,
Please.
what's the reason for, in this patients, to not stop at T9 or T10? Is it primarily concerned about junctional kyphosis?
We heavily debated that. So she had basically 3 levels, if you count it out, of junctional kyphosis. One actively collapsing at the lower end plate, the other one's probably remodeled. Her general walking habit, despite over a year of rehab, was forward pitched, and that's despite ambulatory gait ins. So this is a not closed discussion point. I actually tried to involve the patients, but with her arthropathy pattern, her leaning forward tendency, and at least 3 levels of wedging, I felt that going higher would be better. And again, this is a discussion we have every Friday morning at our indications conference with the probably most quoted author on the subject, that is our partner, Dr. Bob Hart, who basically surprisingly found that the higher thoracic fusions did actually just as well as the lower thoracic fusion patients functionally, had no major impairments of quality of life or everyday life activities, but had a much lower rate of recurrent kyphosis. So this is, as always, a yin and a yang with unfulfilled, unclear benefits. And I would much rather stop at the lower thoracic spine, but in the big picture, I felt in her, given the overall gestalt, upper thoracic spine would be better. I try to give my best possible objective rendition to patients and their families. The only thing that I heavily focus on in terms of being a functional difference is self-hygiene. So the higher thoracic fusions or people with short arms and large trunks may have to modify their body hygiene. So that's the one thing. The other word that I have is falls. Obviously, I have a much longer lever arm. Actually, we're going to see a case of mine where a long fusion failed in a very active person. So I don't want to claim that this is without complications, but in general, in this kind of a setting, my gestalt was there's a less likelihood to have this recurrent kyphosis pattern. But this is, again, an unanswered question. Again, come join us Friday mornings. We bat our heads in bloody on this very question. Dr. Schlauder, with apologies, we've showed this case before, but especially with Dr. Cross, maybe here, maybe not, we thought we'd show this again because I think this is very important on a number of factors.
All right. So the patient is a 60-year-old female who has a history of breast cancer, diagnosed 13 years ago, was thought to be in remission for over a decade. She originally started to develop low back pain and was found to have lumbosacral metastases throughout the spine, possible stress fracture there as well. She was originally managed conservatively, but then she developed sacral fracture, and then our interventional spine colleagues did a sacroplasty on her, which I'll show some pictures of later on. Immediately after the treatment, she came into the emergency department with a pretty profound leg weakness, bilateral foot drop, bowel bladder issues. And that's where we'll pick up. So overall, strength-wise, pretty profound lower extremity weakness, foot drop, extensor hallucis. She had no movement, decreased movement, dorsiflexion, plantar flexion. Also had numbness there. Also had bowel and bladder symptoms. No pertinent labs. And imaging originally in January when she started to get low back pain, she had the CT there on the left side. You can see maybe some increased density within a sacrum. And then you can see there on the STIR MRI, increased signal as well within the sacrum. As you follow the progression the next month, you can see there that her fracture has progressed and she's slipped forward a little bit. And you can see the X-rays there confirm that as well.
So let's stop here. Dr. Cross has just joined us. He's just come out of the operating room. Can't wait to see his OR hat head. Woody, are you live?
I am live, and I just whipped up here and threw on my suit, and I realized everybody's in scrubs. So I wish I would have stayed in scrubs.
Are you wearing scrub pants below that, or Bermuda boots? Like
I can't comment.
You look awesome, man. And
Thanks.
what your hair? That looks beautiful.
It's a little grayer than the last time we saw each other.
Yeah. So I'm going to introduce you formally later. Woody, it's so cool to have you here. You're one of the all-time favorite, I think, in everybody's eyes, trauma fellows at Harborview, and you've made an amazing impact at the Mayo Clinic with teaching and education. Again, formal introduction coming. We are showing a couple of cases traditionally, and this is one where I'd really want to kind of increase our general awareness of lumbopelvic pain. A lady with a little bit of a confusing history of breast cancer in remission. She's a professional. She was very active, fiercely independent, very caring soul who's starting to get more and more back pain. And images are obtained dutifully by a treating physician who I'm not going to identify, but it's a interventionalist who's following her. And so to call it out, sacral insufficiency fractures, plus minus some confounding diseases like oncologic disorders. What should we do to image them, and when should we do what to intervene?
So we see a lot of this at Mayo just for the nature of our cancer practice, and trauma division, gets evolved quite a bit with these. And, we, for me, it's pretty visible, obviously with plain films first, and then proceed to a CT scan with both coronal, kind of coronal oblique reconstructions, as well as the axials that are probably the most important to me. And some of them are tough to see on those images because the fracture plane can be within the axials. And so sagittals can also really help identify where that fracture is. And, they're generally treatable with cannulated screws for the trauma surgeon if they're in the upper two sacral segments, typically S1 or S2. When they're below that in the S3, S4, that gets a little more challenging to provide internal fixation unless you're going to do some type of open reduction, which we've combined on occasion with some of my spine colleagues.
So hypothetically, if you had seen this patient with this early CT scan and MRI scan, which shows the high intensity signal at the S1-2 segment, we don't have coronals here, do we, Abe?
Later on when the fracture progresses.
Okay.
Yeah, earlier.
So would you have indicated this patient for activity modifications, TLHSO, or put screws in right away?
When we see the incidence of the insufficiency factors without displacement, we will give them, and I think they do deserve a trial of non-operative management to see how they do. But we know, and there's data to support this, that patients that have an inability to mobilize, you can, with a half-hour surgery, you can change them from bedbound to ambulatory simply by providing that internal fixation and rebar fixation with cannulated screws that are typically transiliac, transsacral, as long as the pathways are available.
So I'll ask Abe to proceed because we will need your help and input there shortly. So not too badly displaced. What classifications should we use to describe what's happening now between S1 and S2? Yeah,
I don't typically use a classification system to describe it other than being very descriptive. And when we see the axials, sometimes you can see evidence of spinal pelvic dissociation with bilateral sacral alar fractures, which can be inherently unstable, as we all know. So that's what I would critically look at to find out, where that fracture is in the axials. Is it bilateral? Is it unilateral? And is there progressive displacement over time? But this was really easy to fix and was going to be a home run surgery before it progressed with deformity. So this gets to be a challenge. This I would intervene, pretty quickly at this standpoint to prevent worsening. Right.
And Abe, what was done?
Yeah. So if we keep on following along, she continued to have pain, and this is her films from May. You might notice there on the scalp film, she actually got a pain pump for management of her back pain and leg pain that she had from the fracture. She had progression of the fracture there. I have a coronal cut trying to pick up the fracture segment. And there you can see an MRI with a progressive compression. Here I have a 3D reconstructed model where you can see the fracture going through the S1, S2 segment there all the way across.
Our obturator foramen. That's a very elegant picture you looked for, Abe.
Yeah.
That's very transforaminal Schlaudraff view of the ala, the transobturator Schlaudraff view.
Luckily, our imaging department outdid themselves and were able to do the reconstruction.
Woody, you haven't seen that transobturator view of the sacral ala before, have you? Woody, did we lose your connection?
Yeah, there we are. Yeah, I this is a new view, but I may start looking at this a little bit more frequently.
Let's quote our fellow, Dr. Schlaudraff.
First from Swedish.
First descriptor of the transobturator view of the sacral ala.
Love
Very
it.
Descriptive. So classification systems, there's multiple classification systems. Jonathan Plumer, Professor Jonathan Plumer from Germany did a talk on it about a month ago. But to the left, we have the AO classification, not really showing up very well on the screen. But you have A, B, C types. This is a type C3. Then you have the Denis classification system, progressing from zone 1 through zone 3 as it goes more horizontal and further across the sacrum. This is a class 3 due to going completely across. And then you have the Roy-Camillo type. Type 1, 2, 3, depending on whether it has slipped at all, retrolisthesis or anterolisthesis, the type 3 Roy-Camillo.
So Woody, we have tried with the AO system, and I take a small amount of co-credit for that to bridge the gap to our trauma colleagues. Yet here we have an eminent major name in trauma surgery in North America and beyond who says there's no need for a classification system. And we tried to do this interdisciplinary, like Jim Krieg was on that panel, Carla Bellabarba. So many people who really are eminent in the trauma world also, like you. Where have we failed? Is this just irrelevant? Does it just matter if it's displaced or not displaced?
We use this classification system and others on every single case to log it in our fracture databases so that we can pull data to find out how these patients do. But this does work. Sometimes, and with our trauma center, it's hard when the residents and fellows call us at home and say, I have an AO C2 a sacral fracture, and then for us to immediately recall what that is can be challenging. So descriptors are great for over the phone conversations, but I would say descriptors are your classification system that we're showing here is integral for our research purposes to make sure we're doing the right things. So it has high value when we look at it in that arena.
There's a big smile on my face now. Thank you for that endorsement. But it's safe to say that this patient went from a C0 to a C3. Is that right, Abe?
Yeah.
And from a Denise zone 3, which was present in the beginning, Roy-Camillo type 1, non-displaced, but through the spinal canal, as any transverse fracture mandatorily is, to a now zone 3, Roy-Camillo 3, which is a whole different ball account. So going back to the displaced films, maybe this one. Now we have a mess. So we can agree that this is a C3 now, Woody, and Roy-Camillo 3. Fair?
Yes.
What would you do now? I've seen you put magic screws in and pretty devastated pelvic ring and lumbopelvic injuries. What would the great Woody Cross do for this patient?
At this stage, it's we would look and see, I guess her neurologic deficit is progressing. So I would consult you and other colleagues to find out, is there a need to do a formal reduction? And if the patient's intact and doesn't have loss of bowel or bladder and no neurologic deficits, then I would start with the axial, coronal obliques and see if there are some pathways to provide transiliac, transsacral fixation to fix this in situ to prevent worsening. And then that would really solve the problem for her.
But these displaced upper sacral fragments, where you see the posterior body of S1 is eroding on that left sagittal view, even the great Chip Rout, Sean Nork, Keith Mayo collective always struggled with those and didn't really like to put screws into that S1 segment. Do you find that's feasible? Are modern advancements by some companies, like I want to, by the way, say hi to Carlton, who's on the conference this morning. Is this technically feasible to get a meaningful in situ fixation, or do we have to somehow lever that into an open reduction, better alignment?
It would be, and I'll touch on this in my talk later, but it is 100% templating and really seeing what you can find on the imaging and doing some different coronal or different reconstructions to find out your pathway. If you cannot find a pathway, then that raises some questions. Do they need some type of further fixation like lumbopelvic? But usually you can find a pathway for a 6, 7, 8, 9 millimeter screw to go across there and stabilize that unstable lateral segment.
So now, drum roll, we'll see what happened to the patient, Dr. Slaughter.
To summate that, most spine individuals, spine surgeons would do some type of titanium alloy thoracolumbar fixation for this. Fortunately, to stabilize it, the patient had a sacroplasty with bone cement injected. And there I have intraoperative view on the left and on the right side. And you can see the bone cement didn't really necessarily stay within the sacrum. And here on the CT, you can see that we have bone cement leaking out and actually encasing nerve roots bilaterally. After this is when she woke up with progressive weakness and bilateral foot drop, likely from the exothermic reaction of the bone cement possibly on the nerve roots, causing a nerve root injury and also compression. Also had
we see an actual neurogram by methylmethacrylate. You can see the L5 root track, and you see the S1 takeoff filled with methylmethacrylate now. So Woody, this is obviously a very difficult situation now. Tell us about your thoughts on sacroplasty. Again, you're I keep saying that, a very experienced trauma surgeon. Yes, the gray hair helps, but you've seen it all. When and where is a role of sacroplasty given? And do you see that in at Mayo?
So I think for my practice, it's a little bit of the numerator-denominator equation that I'm only seeing the numerators as sacroplasty fails. And they don't, in my mind, give us a great amount of stability, especially in a displaced fracture like this one. They do have significant roles, I think, to prevent further compression of the vertebral bodies, but in the sacrum in particular, again, numerator, from what I see, they don't play a big role in providing stability, especially when you're looking at a shearing force across there. So in my hands, I would much rather fix this. I mean, this is the surgeon speaking, right? With internal fixation and titanium or stainless steel to help really stabilize it with rebar. So in my mind, this was potentially maybe a poor decision for sacroplasty when ORAF and surgical options are available.
So the sacroplasties basically go into the sacral ala, right? So have there been mechanical studies done to show that it actually do some difference, let's say in an in situ sacrum? I'm not sure how to model that. I've done some lumbopelvic studies, but are you aware of anything that has actually shown the mechanics?
I'm not.
That has shown the mechanics of lumbopelvic fixation for sacroplasty?
No.
Yeah, this is interesting to me because this has become a big market and a big thing. So, that's something. But now we have a real problem. So now you have cement outlining the L5-S1 nerve tracts. You have a progressive spondylolisthesis at S1-2. You have neural canal compromise. At this point in time, do you offer this patient who has a cancer history surgery, or do you kind of just say, c'est la vie? Another stimulator, add a stimulator to the pain pump?
Yeah, exactly. I think, this again, what was easy is now a challenging, but I do think that this clearly has demonstrated some progressive collapse and deformity, and I do think stabilization may benefit her at this point.
All right, Abe, show us what we did.
Yep, so plan, like we talked about, decompress, stabilize, treat her now foot drop, leg weakness, and cauda equina. So intra-op, here we have some photos. You can see up on the upper left photo, we have Dr. Skuian spreader, which is a small laminar spreader we usually put in the disc space to try to extract and try to reduce the S1 spondylolisthesis. And then we instrumented above as well. Did S1 bilateral modified iliac instrumentation, and then screws into 5, 4.
And we did augment those upper screws with cement, and we could not do bilateral S1 screws because one side was just too eroded. There was nothing left. And so how did the patient do?
She's did very well. Her pain, her post-op, her pain improved very, very well. She actually wanted to have her pain pump removed. And then I saw her in clinic with you a month and a half ago, and she was doing much better strength in her legs, regained predominantly all of her strength in her legs, although she still does have some neuropathic pain from bilateral lower extremities, probably from the nerve compression that she had and from the nerve irritation, but overall doing well.
So can you show the last X-ray? So Woody, so we chased after the cement, but I could not safely, I didn't feel comfortable removing it all. Just critique us. By the way, the pain pump has been removed now, so she had a hate relationship with that thing, and our functional neurosurgical partner was so kind to remove this. So that's gone now, but critique us. I did not fully reduce her. I kind of tried to pull her back and restore her lumbosacral alignment, but as you can see, I did not seek to fully pull her back because I was not totally sure that I could get a fully reestablished alignment with the bone purchase that she offered, despite augmenting the screws with cement. Any thoughts, critique?
I think it's great. This is what she needed. And by just looking at that displacement on the left image there, I mean, getting a transiliac transsacral pathway through S1 would be extremely challenging. And so this is the perfect indication for lumbopelvic fixation. Hard to know about what S2 is doing there, if they're depending on what that pathway is, but she does not look like she has a dysmorphic sacrum. So I do think that the lower sacral segment might be challenging to get a transiliac transsacral screw across, which could have augmented the fixation. But I think this is exactly what she needed, and it looks great.
Had I had you as a partner here, would you have tried to fire a SI joint across there, a SI screw across to kind of augment my fixation so we can have an independent cantilever or crossbar fixation, I should rather say, of S1 relative to the ilium?
You have put nice iliac fixation in there as is. So I don't know how much it would have added. I think with the long pelvic fixation iliac screws, it looks great as is.
Do you have an interdisciplinary group at Mayo to kind of look at these problem fractures? Like we're joined by Dr. Glenn David, and we have the great pleasure of having an interventionalist who did not do this procedure, by the way. So we can kind of immediately elbow to elbow review indications. Do you have an interdisciplinary panel that looks at these problem patients?
We do. We have we operate in concert with the neurosurgery, orthopedic spine surgery, and we have a very robust interventionalist practice with radiology, with a few different disciplines that get involved in this. So we do review these to talk about the different options when they present. And when they're progressively displaced like this, I mean, this is in our practice a relatively rare case, and this one would be where the whole group would come together to figure this out. But yeah, so we do indeed have those types of practices and relationships here.
Great. All right. Any thoughts, Abe?
One of the big takeaway points for me is, as a neurosurgeon, is when you see that earlier on in your practice, like in the land of potatoes in Idaho, do an early SI perc. Minimally invasive fusion. And
we'll hear Dr. Cross talk about that and give us a trauma perspective. Thank you. Great presentation. I know it was a repeat. Next, we have Dr. Jim Hicks, originally from Alabama. And he is also very happy because he is a Georgia fan and had a reason to celebrate the other day.
Yes, 2 years in a row. It's kinda
So
nice.
2 years in a row.
What a time. What a time to be alive. All right.
So
So let's jump into the presentation. So 76-year-old male undergoes a staged XLIF 2 to 4 and T3 to pelvis fixation in 2019 for degenerative scoliosis and a previous T7 compression fracture. A year later, whilst taking care of his property, he falls, developing interscapular pain, and subsequently develops myelopathic symptoms. His examination after his fall indicates some weakness bilaterally and obviously issues with his posterior tracts. This is his original films prior to his large fusion with degenerative scoliosis, and within the mid-thoracic spine, there is a compression fracture. These are his postoperative T3 to pelvis and XLIF 2 through 4 there.
So this is a case we're showing to demonstrate the problems of long fixation. The first case we showed, Woody, was a long fusion that I did, and the patient has done very well so far. This patient had a long fusion done by myself and Dr. Skuyan, and he did very well. He's an extremely active farmer, and we can start seeing trouble. I think this is not the first postoperative standing film, but we start seeing problems because he started losing sagittal alignment.
Right. So before we address his lumbosacral junction, this was him after his fall, then developing myelopathic symptoms. He was subsequently extended and did get cage placement, some anterior column support. It's another postoperative film there.
So again, this is the caveat. A long fusion begets potentially further surgery. So to paraphrase what Dr. Martin said before, they're never completely done. And this patient actually did quite well, but then fell off. There are different views of what happened, but the original story was that he fell off of an industrial-sized tractor or something like that. And again, we did not restrict that. I'm a little bit less aggressive in letting patients return to full activities, but he was going to do what he's going to do anyways. And then he presented late in the afternoon, and Rod and I, remember that, took him to the operating room emergently because he was severely myelopathic. I think he was an Asia C spinal cord injury. So I just wanted to show that as a honest caveat towards long fusions, as I endorsed a long fusion on a other patient before. But the main focus now is to talk about the lumbopelvic junction in this patient.
The caudal junction there. So eventually, I believe it's a couple years after his cervical spines, complaining of hardware prominence caudally. And there was a question whether or not he was having pain at that time or mechanical type pain, but mostly complaining of prominence, especially on that right side. And here are the plain films. If you'd like to discuss anything here.
Yeah, so again, we can see this is an active man. He had a femoral neck fracture. I know you did one of the sentinel studies on femoral neck fractures, Woody, but what he's developed over time is a sacral fracture despite lumbopelvic fixation. I thought I'd done a nice job restoring the lumbosacral alignment with cages, bone. This is not a healing impaired patient, but clearly he developed an S1-2 kyphotic insufficiency fracture over time, and he has what we really dread, windshield wiping of iliac fixation, and so he has a non-union of the pelvis. So the gist of the message is, Woody, should we, when we do these long fusions, routinely fuse the SI joints or not?
So that is an unanswered question, and that is something that we're looking at closely. We are in the midst of designing a study here to look at, hopefully, I think a randomized study, looking at adding on fusions to these long segment fixations to see if we can prevent deformities like this down the road. So that's unanswered. What's my gut feeling? My gut feeling, based upon seeing patients that present with these type of deformities and post-operative long segment sequela, is that it does play a role to fuse the SI joint somewhat prophylactically to prevent this from happening.
Yeah, this is, again, deeply frustrating to us because we spent a lot of time and effort on him. I thought we had a perfect alignment in the beginning, and then he wobbled loose his long iliac screws. I don't know what they were, 100 plus millimeters, but we did not do a formal lumbopelvic fusion. Rod, do you do routine SI joint fusions? And I'll ask our colleagues also.
You know, interestingly, we don't. And I think I agree with, you know, everyone. There's no, I think it's not common to see this, but I think we see a lot of haloing around the pelvic screws.
Yeah.
And I wonder if, even though I think we fuse L5 and S1, I have a lot of patients who always complain of SI joint pain who never had SI joint pain. So I wonder if some of that is that there's a stable pseudoarthrosis there, but I don't know the answer.
So our colleagues, Mike, so should we fuse the lumbopelvic junction routinely, SI joints? I mean, this is very frustrating. This is was well prepared, well thought through. We did a big surgery on the patient. I admit that, arguable in retrospect, how many levels to go. So I just wanted to show us to balance my enthusiasm for the other case. But this is a metabolically healthy guy. He's super active, as the injury mechanism showed. But he wobbled loose his lumbopelvic junction and long fixation, stable bone. Should I fuse the SI joints? Should we do that nowadays? What do you suggest?
So, I mean, the surgery worked on this guy. I mean, you kept him doing what he wanted to do into his mid to late 70s. So I think in that respect, the surgery was successful. But again, we're treating these long-term sequelae. I think fusing the SI joint then is going to, transfer that stress that the middle portion or the upper portion of the sacrum has been bearing. So it's less likely to fail there. My question, though, is you get a nice solid SI joint fusion. Someone that looks like they've got ankylosing spondylitis, and you can see the nice trabecular bone flowing down there. So now all the forces are getting transmitted to the femoral next. Do they fail next?
Unanswered question. This man already had a femoral neck fracture. I think that post-dated our fusion. So I followed him. This is like a 5-year saga now. So you're spot on. Hip joints come next. And that's a good point. So let's go forward, Jimmy, so we can see Dr. Seidel's last case.
He then undergoes. So we revised the hardware, debridement of what was suspected to be non-union down low. He did get a bilateral SI joint fusion with chat bone, copyright, and revised with a quadruple iliac screw fixation. And so here's what that looks like, standing films.
So we enhanced the pelvic fixation. We used different tracks. You can see the haloing around the previous ones, and we did the Dr. McGuire special fibula allograft multi-level fusion in there. How did you do from this?
I did well. And so he's about 5 to 6 months out now, I believe. And so we'll continue to follow and see how he does.
So Woody, biomechanically and osteologically speaking, wouldn't it make sense to compress these from lateral also? I mean, when I see these constructs, and again, these are massive screws. They're 120, 140 millimeters large, 8.5 millimeters long. One is so these are stacked screws. Wouldn't it make sense to compress this from lateral also? I mean, when I see this, I just want to have some symmetry there, the cross fixation for the crossbone.
So so you may know my philosophy. One of my philosophies with the SI joint is to provide massive compression, because I think the compression equals stability. I also know that, and we all know that the iliosacral articulation is relatively a tongue and groove type fixation. And if you compress a tongue and groove articulation, you get innate stability. So our routine is to provide significant compression and then neutralize those forces in compression, which facilitates not only stability, but the eventual fusion where you do get that bridging trabecular bone from the ilium to the sacrum. And I think that portends, a durable long-term outcome.
All right. So how do you do from this?
I did well. And again, we'll see how he does. And
we'll see how he does. The other femoral neck might be next. We'll have to call upon you, Dr. Cross. You take out-of-state referrals, do you?
Yeah, I love them. But to that point, I think about that a lot. About, we talk about adjacent segment disease, and I always say that the most caudal aspect of adjacent segment disease is the SI joint. And then when you look at the degrees of motion at the hip joint and the hip socket, as long as it's not arthritic, it's not going to go south. And I will lead in this in my talk, but if the patients have an arthritic hip, that is a tremendous amount of force on the SI joint and the low back. And so there's been a paradigm which I think needs to be addressed about the joint surgeons sending patients to spine to get their spine fixed before they do the hip. It should be the opposite. And I'll show some data to that effect, that we should be looking at the hip joints way earlier than we are to help unload chronic low back pain.
That's a great point. Last case, 5 minutes. Dr. Seidel has a different variant of lumbopelvic junctions.
Yes, we're short on time, so I will move quickly. So this patient is a 78-year-old male. He came in complaining of low back pain, left leg pain, bilateral dorsal foot numbness. He is status post laminectomies with gutter decompressions from L2 to L5, with posterior instrumentation from T10 to pelvis and A-lifts from 3 to S1 performed back in 2014. No significant medical history that's contributory towards what we're talking about. So on exam, he's got a little bit of weakness distally in that left leg, a little bit of sensory changes as well. Tenderness to palpation around his lumbosacral junction, though, that's important. Positive straight leg raise. And he has very prominent hardware and decreased range of motion. And of course, gluteal atrophy with claw toes. So you can see here he was kind of on the clock from the get-go after his primary surgery. He's got this non-union at L5 S1 resulting in hardware failure, where you can see the rods are out of the S2AI screws there with a grade 2 anterior lethesis of 5-on-1. He's got an SVA of about 10 and a mismatch of about 30 degrees still.
So again, and the hardware has disengaged from the pelvic fixation. This was not done by Drs. Osgood and myself, but a partner that we know. We see the radiation seeding in there. The point here is lumbopelvic fixation, especially in long fusions, is one of the most thankless, difficult things to actually achieve satisfactorily. And this man was considered cured and healed. And then comes back again years later and is more unhappy than ever, and his rods are coming out. It's a very sophisticated man. Another point was he had A-lifts done at 3 levels by our colleague, and this was a very traumatic experience for him. So this bears into what we did here. Carry on.
So here's CT scan just highlighting basically what I just showed you. You can see the obvious 5-1 non-union there. He's well fused everywhere else, and obviously the hardware has failed.
So S1 screws are loose, pelvic screws are loose. And again, the failure points, you said it before, Woody, the distal junctions are so failure prone. This is a patient who solidly fused, was actually very happy, and then just got increasingly worsening pain and now has lucency. He has no overt signs of infection, right?
No, no.
We obviously are always leery of that, but infection parameters are not great, are normal. Junctional collapse rostrally, but so far asymptomatic is noted.
Yeah, and his DEXA was fine. I mean, it was 2014, but he was not osteoporotic or penic.
And in light of his prostate cancer, we did not want to give him Forteo or something like that.
Agreed. So this patient underwent revision of the hardware from L2 to pelvis, revision decompressions, partial corpectomy at S1 and L5 with removal of that previous ALIF. He had placement of bilateral expandable cages at that 5-1 space and SI arthrodesis. You can see here, hardware is very well placed. There was a little bit of an increase in his lumbar lordosis to approximately 50 degrees, so his mismatch is now a little bit better than before.
So we did not go from anterior after he really did not want to experience the problems he had the last time. I think there may have been a vascular injury also. So we did something we've done quite a bit, and that's bilateral L5 cages, so we can get some volume in there and yet avoid an anterior procedure in patients where this is just not that desirable. So these dual cylinder cages have been written up by Alan Daniels. We have a series that's probably larger than that. Mechanically speaking, again, in our world, there's a big difference between so-called S2AI screws and transiliac screws. Woody, is that something that you mechanically have looked at? Do you have, as a trauma surgeon, a preference?
No, not particularly, and certainly not in this situation. My main familiarity is with the transiliac transsacrals, but in this situation, we would, we do a lot of the here combined SI joint fusions and revision of the lumbopelvic fixation. And so I think the key point is just getting stability of the SI joints like you did.
So we put the fibular graft and again the McGuire graft, which is my favorite go-to, and you can see them crisscrossing the joints and interfering there. Any further follow-up?
Yeah, so he's only about 6 weeks out. He's improved from prior. He's still dealing with some of post-op discomfort that's getting better, some residual numbness, but it's resolving in his feet. So overall, he's improving.
Dr. Martin or Dr. Covey, any thoughts? So there's a difficult revision situation, frustrating lumbopelvic non-unions, the bane of our long fusion existence. Any thoughts on how to salvage that?
Look good to me. How in the world did you get those cages in around those L5 nerve roots?
It's actually pretty simple. Not simple, not true. We need improvements of device manufacturing. We put the cages in these expandable titanium cages horizontally, and then pivot them, distract the spine, pivot them 90 degrees into a vertical position on both sides, and then distract them. Actually put in one side horizontally, then distract it and restore length. We plan it beforehand so we can kind of see what ideal height we achieve. Honestly, we don't have great cages that allow this pivoting maneuver to take place very reliably. I switched away from PEEK towards titanium for a variety of reasons, but one of them is that the interface is very vulnerable. And in fact, in this patient, disengaged during surgery. So I had to extract a cage, get a different set opened up. We actually have 2 sets open. So I don't want to proclaim that this is terribly easy at the lumbosacral junction, but the concept actually works quite well. Going in horizontal does not stretch the roots, and then pivoting it into a vertical position.
How about Jens? What did you do with the connectors? Because my experience with these inline, wedding bands, I mean, all this stuff, it's a major point of frustration.
So I think that this particular one, I don't want to mention the manufacturer, has been a breakthrough because there's an inline one segment, so there's no welding. So this takes one failure point away. And this is a fully fused area, and we put interference screws into the old fusion area. So hopefully this neutralizes this connection. But you're quite right, and we're looking at that actually in a larger lab. This is an unresolved issue. This has not been that well studied. Thanks for bringing that up.
Mauricio is working on it, but I haven't seen anything so far. So hopefully we'll get it published soon.
Thank you, Chris. I don't want to shortchange our invited guest speaker. Dr. William W. Cross, affectionately known as Woody, is a famous and well-known trauma surgeon. We intentionally invited a trauma surgeon to talk to us, a spine surgeon, to educate us about the SI joint from a different perspective, mechanically, but also bone healing wise and fixation wise. Let me just quote something that Dr. Cross says, and that's the motivation of what he does. And I just thought this is so inspiring. His passion for trauma is this: what's different about the trauma world is that you're taking patients at their worst and trying to get them back to where they were right before they got hurt. And this is something that I find so cool and so inspiring, and hopefully we as spine practitioners are inspired similarly. He joined the Navy first. He served with our Marine Corps with distinction, working his way up from a hospital corpsman all the way up towards a surgical career. And he attended the University of Minnesota Medical School. He did his residency there, and famously he did a trauma fellowship at Harborview and became, as I said earlier, one of the all-time favorite trauma fellows there. He has been an active pillar in the educational programs at Mayo, where he works, and he's educated numerous residents, now a whole generation. And he also served as the chair of the Division of Community Orthopedic Surgery. The list goes on and on. He has obviously had a major distinction in pelvic trauma surgery, and from this perspective, he's going to educate us more about SI joint physiology and repair opportunities. So Woody, it's great to have you here. Thank you for joining us and batting leadoff in 2023 for STED Talks.
Thank you. Yes, that was fantastic. I really appreciate this opportunity to speak, and The SI joint has certainly become a passion of mine, and is actually, I just finished up a primary, and I'm about to do a total hip on a patient from my SI joint clinic. So this is very apropos for us today. So I'll go ahead and start along. We'll talk about specifically a kind of a failure and avoiding failure when we do SI joint fusion surgery. So for disclosures, we did design a system here at Mayo Clinic based upon our revision practice, and I'm also a board member of the SI Joint Experts Group in the kind of international group. And if anybody's interested in SI joint, this is a fantastic multidisciplinary group. So I gotta talk about why listen to me, and we'll talk about our practice, diagnostics, treatment philosophies, and then we'll concentrate on failures. But I think the take-home points from my talk, which we'll talk about again at the end, is first and foremost, with any SI joint issues, correct diagnosis is key. Treat the hip first. If they have issues with the back, I usually treat that last. Revisions, when they don't go well, can help patients. And so you need to make sure you set realistic expectations up front. And again, meticulous templating and planning. So why listen to me? It's really, I really have come to enjoy all things pelvis, and then the SI joint in particular. And with the inception of MIS surgery in kind of 2010, 2011 is when I started doing this. We've done well over 500 SI joint surgeries, over 50 and revisions and growing, and really have turned Mayo Clinic into a nice hub for SI joint surgery. So, again, as Jens mentioned, ortho at the U, and that's where I met, Dr. Swinkowski and Polly and Stark, Polly and Stark being pioneers in the SI joint world. And then trauma fellowship is where Jens and I got to meet, and stayed friends since then. And that's my trauma group in the bottom right that I spent, that great year out in Seattle training. As we all do, when I got to Mayo Clinic and started my practice, I gave a talk on how to fix the pelvis percutaneously. Well, since that talk, Dr. Nasser is in the audience, who a lot of you probably know. And he was approached by a group that was doing an SI joint product, and nobody down here at Mayo was doing it. And he said, that looks a lot like an SI screw that Cross has talked about. Go talk with him. So I met with them, and we did a bunch of cases with good outcomes and really fulfilled this niche at Mayo that was unmet. And kind of the rest is history. And when somebody found out that there's a Mayo guy doing SI joint fusions, the waterfall started, and they just kept and keep coming. So going to my residency and my training, all along, my philosophy has been like when we fuse subtalar joints and MTP joints and everything else, is we get a good, solid, durable fusion, eliminate that motion permanently. And no orthopedic surgeons get it to fuse and be done with it. And that's kind of us just scraping out an SI joint there open. 12 years later, we're rolling, and we have a great clinic, and it's really been, I do, still a trauma surgeon in training, but probably a full third of my practice now involves adding on SI joint issues. So how about trauma in the SI joint? Well, we see this routinely. This is a really complex pelvic ring injury, complete dissociation, got this tile C of the right hemipelvis. And, we reduce these open, and they, don't do great. And when you do them open through a lateral window, this is what comes out. This is, a 3-centimeter piece of cartilage that's sheared off of the SI joint. And these patients can predictably get some form of arthrosis. Not always symptomatic, but they certainly can be. So my current practice, all of us see SI joint stuff, but this is kind of our standard diagnostic criteria. And along with the history in this exam being integral, I also think that injections are absolutely key, because it gives us another objective evidence. And injection risks are real, and you need to have your injections be placed like this, where you are getting no intra-articular or extra-articular spread, and it's intra-articular and well done, and you can watch the injectate go in the SI joint. These are from my practice and are unhelpful. And they are such a false positives with these. So if you're getting an image like this, they need to be redone, maybe under CT, because this is unhelpful. This is helpful when they give you a report like this immediately after that they go from a 10 down to a 2. This is unhelpful when they just simply give you a pre-procedural pain and don't tell you exactly what the results were. So I'd urge that our proceduralists and so on would just take 5 to 10 minutes and reassess afterwards. If you're confused on the SI joint, again, focus your evaluation on all other possible causes and either eliminate them or set realistic expectations that the SI joint's not going to cure facet issues, but may cure just the SI joint. And we can talk about this later if there's time, but I always talk about the SI joint being a safety valve. And if 5-1's super stiff, the SI joint's going to move to offload 5-1, but you take away the SI joint, 5-1 may experience some increased motion and some pain. If they have an exam consistent with hip pathology, I will always add on a hip injection to really try and see the interplay between the hip and the SI joint. Same thing with facets above to see if there are issues. So my caveats, based on my practice, is if they have hip pathology, address the hip first, because that completely changes your dynamics posteriorly. If they have profound facet issues, address the SI joint first. Hip issues, or the patient from my clinic sent to me for SI joint pain. We got her an injection, but during her interview and exam, her hip was very symptomatic. Her imaging showed posterior wear patterns, some cysts in the femoral head. So I get an ultrasound guided hip injection, relieved her pain significantly. And so we opted to proceed with that. And here are her outcome scores. She's a year or something out now. SI joint pain continues to be 100% gone. For those of us that use the PROMIS scores, there's the crossover sign that we're always looking for, showing, really a greatly improved function. Here's a patient that Dr. Pauly and I actually share. Profound facet joint issues in the back, but also SI joint issues. Injections gave her great relief. Facets also gave her some relief, but we opted to proceed with fusion surgery. Her left at a couple months post-op now is 100% better. The right is only 75% better and improving, but it's unrealistic in this patient to think we're going to get her down to a 0, but we can definitely make her more functional. When things after you do a fusion don't go as well as you'd hoped, what do you do about it? Well, I think you have to figure out why did the surgery fail in this particular patient? Did you get the wrong diagnosis? Was it the hip? Are the facets really truly the issue? Is it a radiculopathy that we're not picking up? Were there technical issues with how we did it? Is there too much motion across the SI joint? Is there not a good fusion going across there, or good fixation? Or are there some patient factors which may be contributory? So looking at technical issues, these are pretty obvious when we see these allografts and plugs going in there with loosening. This is relatively obvious, what's going on here. And here maybe a little less obvious in some of these cases. When loosening is overt, it's pretty easy to pick up. Sometimes it's not real easy to pick up, and you really rely on injections to help you. And if I look at my practice and revisions, these loosening patients in particular, we reviewed a few of these a number of years ago, and we looked at kind of where they ended, and we looked at CT scans and Hounsfield's units in the sacral ala and the sacral body. And we found out, when we looked at this, the sacral alar bone is extremely, I call it butter bone, just so there's no bone density in it. In fact, got the Hounsfield units of an average of 0 in some cases, where the body was up near 175. When we looked at where these implants ended, 100% of the implants ended at zone 5 or lateral to this, with most of them falling into that zone 3. And that's a high risk factor for loosening in the sacral ala. So how do we work these patients up? This is my primary protocol and my revision protocol. Positive history, exam positive, imaging, loosely suggestive but not critical, and then an injection that I can see with my own eyes that's perfectly placed, and I can make some decisions on that. And the caveats on the right are primarily for primaries, but also can play a role in revisions. When we work up and evaluate these patients for revisions, it's consistent with pre-op. I never put steroid in the injections because I don't, I come from adult recon mecca here, and we don't put steroid in joints that have metal in them. And so I'd follow that same philosophy with the SI joint. And then, I also counsel them on realistic expectations. Here are some injections into here. And again, this is critical that they're well-placed injections by somebody that you trust and does a routine job. And on the right, I think this is an interesting one. This is just from the other day, but you can see the injectate going up through the implants all the way up into the SI joint. And so it just tells you that, this patient probably doesn't have a robust fixation back there, and maybe a reason why they're still having some pain. if you've made a decision to revise, to do an SI joint revision surgery, you have to determine what your goals of surgery are. And for me, I like to do compression, scrape out that joint and put bone graft in there. You have to anticipate bone loss from removal of these implants. Do they have a bone density issue? Do you need to address that first? And then do you want to do an open approach, either anteriorly or posterior dorsal open approach, with which a couple of my friends do, or a lateral approach, which I'm the big fan of, just because, I'm a trauma surgeon. Anterior open approaches, in disclosure, I don't use this that much anymore, but there are some circumstances where I do use it. If your endpoint is radiographic fusion, nothing will beat an anterior open approach. And this just shows you, is we all know, the amount of bone graft that you can get from the gluteus pillar and inlay into the SI joint is profound. And so this is one of the big advantages of doing a lateral window open approach. And this is just kind of a short picture of us inlaying all that bone in the SI joint. Those homins are impacted into the lateral sacral ala anteriorly. So just a robust fusion mass that is possible. Percutaneous revision without doing open, it gets a bad name because it's a perceived difficult procedure, but it's actually not. Most implant companies have some removal systems. Some are much more well engineered than others. But as long as you have meticulous planning of where you're going to put your pathway and how you're going to take them out, they're not that hard. Implants do matter. I've revised, I think, just about every implant out there. And, the screw types are easier to take out for some obvious reasons. These triangles are also pretty easy to remove. They do have a very good chisel removal system out there for them, which is great. These posterior allografts, which I showed in one of those slides before, are easy. You just ignore them and blaze right through them. And then these posterior-based cages, they're placed pretty caudal and posterior, which leaves you room in the anterior SI joint. So we'll go through a couple of case examples about how we do it. This is a patient that has some screw type dowel devices, 38-year-old phy ed teacher, chronic pain, 2 years status post the fusion surgery, and really never had any relief, and was actually a little bit worse. So she gets a standard eval. I get the flamingo views there on the bottom to look for pelvic instability, standard inlet outlets and a CT scan, and get the injection. Injection's well done. Gets her from a 7 to a 0. So I offer her surgery and we get the removal system. These screw type devices, if they are ingrown and just won't budge, I always have trefines on standby to over drill them. These are, I believe a 12 millimeter outer diameter. So I use a 12.5 millimeter trefine. I really am a fan of these metrics tubes for MIS and the quadrant retractor system to help see. Then I sit down with a headlight and a stool and use some long instruments to help expose and directly look at the implant. This is my template. You can see on the right side, that's my proposed trajectory for my revision implants. And then I recannulate the devices, drill through them to help break up any bone with inside. The top one came out easy. The second one was pretty ingrown, so I was not coming out easily. So then we dilated, have that quadrant retractor system that you guys know, and this is the trefine going over it, and the trefine loosens it up, and then you can extract it out with the standard removal tool. This is me just doing this turns into a routine primary fusion surgery. Put our device in there. This scrapes around and decorticates the SI joint, and put a little bone graft into there, which is a combination of allo and autograft, and then put the screw across, which gives a nice compressive force to the ilium. And then we neutralize that force with an anti-rotation screw as well. And again, here's her crossover sign. She gets an 8 down to a 0. Her promise scores are improving, and she does remarkably well with a solid fusion mass between the ilium and the sacrum. A brief case, removing some triangles, 69-year-old male, parachute injury from back in the service, had a fusion in 18. This is kind of par for the course with some implants where they have a period of relief before implants loosen. And he has progressive pain. Same routine again, we get injections, well done injection, lowers them only from a 6 to a 4 based on immediate feedback. Phone call later on gives a greater than 50% relief of pain. He has overt loosening and chose to proceed with revision surgery, with realistic expectations. Same thing as before, removal system from the vendor, tubes, quadrant, headlight, stool, long pituitary bovie, looking directly at the implants. And this is our template. We're looking at the upper sacral segment on him. And you have to think about bone loss in these patients, but we're going obliquely to the implants. And so our pathway is pretty well preserved, especially if we're able to get that chisel guide and go right on the implants under direct visualization. Just as before, we're recannulating. We're drilling it out from the inside, metrics, tubes, quadrant retractor, chisel them out, remove them with the removal instruments, and a standard routine fusion surgery with pin placement, drilling, decorticating, bone grafting, compressive style implant, then compressing. And this one does not get a secondary implant, secondary to the holes from the previously placed screws. And here is follow-ups, X-rays. I did an open revision a while back, and just so we do open these up on occasion. This patient was a 62-year-old female. She was in the Army and had slipped on some ice back in the Army, was fixed in the South, and had a primary in 19, did not do well. So for the revision plan, they just added 2 more fixation devices and didn't make it better. To talk about patient factors, she is on quite a bit of narcotics with Percocet, patch, Dilaudid, gabapentin, and so on. So realistic expectations up front. But what's interesting about her case, when the theory is to add more, she actually developed a sacral stress fracture at the tip of all of her implants, which may be related to why she was having so much pain. So we got her injection. The injection went to a 7 to a 4, but you call her on the phone later and she recounts you 100% pain relief from the injection a few hours later, and would like to proceed with the revision surgery. So we decided to do this open through a prone approach. So we do, which is a relatively standard trauma approach for an ORAF of a pelvic ring dislocation. So right off the PSIS and anteriorly, removal set, anticipated bone loss, given we're taking 5 plugs out. So we call for a femoral head bone graft with a bone mill. And I knew we were going to have bone loss, so we needed a bigger washer. So we used this star plate, which I'll tell you about. So the template there on the right side, upper sacral segment, templated. I know what our safe zones are. I know where we're going to go. And one of my buddies, you guys may know, Jeremy Fogelson, removed some of the iliac screw fixation and was going to put another screw in there for added fixation when we're done. But this is exactly routine. There's the chisel going in. There's the retractor system. We're looking under direct visualization, but it's done percutaneously through the buttocks. And we move the implants without challenge. Routine SI joint fusion surgery, kind of decorticating, creating a nice fusion zone, and then bone graft it. Put the screw across it. Here's that plate that we use to increase our lateral surface area. And as we compress that down, you can really see it compress the SI joint and give her some really instant stability. And there's that lateral view. There's that added supplemental fixation for anti-rotation. And there's kind of an intraoperative view of what that looks like through incision. The head's to the right, legs to the left. And that's actually just a patella star plate. It's interesting. So hey, that's her a fusion mass at a year, 1.5 years post-op. So, but in disclosure, her PROMIS scores didn't show great improvement over time. But I really am a fan of asking patients the SANE score, the single alphanumeric score, for how well they're doing with their SI joint pain in particular. She was 80% better with the pain that we went to treat preoperatively. So she was significantly improved to the SI joint, but our outcome studies in the SI joint are poor. We're looking at the ODI, we're looking at PROMIS scores for generalized pain. So it's tough for us to look at outcomes as they relate particularly to the SI joint with these issues. Pearls for success with revisions based upon these patients that you saw, you really have to get a good diagnosis, eliminate other causes, and set realistic expectations for their projected outcomes. And we just published our series of revision outcomes. It's in press right now, but we did the study a year ago, looked at a number of fusions between 17 and 20. I was gone in the middle of that for about 14 months. Not operating, but we looked at these outcomes here listed. Pain or the patient criteria is the same as we've talked about with exam, history, imaging, and injection. Typical surgical technique, which was highlighted in those other 3 cases, are recannulate the devices and proceed with hardware removal and template your pathway. Scrape out the joint with decortication to help create that fusion zone, bone graft, put your compressive implant in there together to really provide some good compression across the ilium into the SI joint to give them instant stability, and then provide an anti-rotation screw if able for additional stability. So in our series of these 21 revisions, the average age is 55. They were a skinnier cohort, the BMI in the 20s, and 20 of the 21 were done through MIS approaches versus open. The vast majority of them were from pseudoarthrosis without fixation failure. And then we look at outcomes. I mean, the ODI is better, but it's not a home run. And this just shows that there's a lot of other things going on with revision cases that are probably playing a role. Same thing with the pain score rating from a 6 down to a 3. Again, not a 6 down to a 0. So setting realistic expectations, but their SANE score, for the most part, showed these patients are 75% better with their SI joint pain than they were pre-surgery. So and we did identify bridging bone with these revision surgeries. So I think we're limited. There's only 1 year out. It's only me, my series. It's not a multi-center, but you do make these patients better. You lower their ODI, you lower their pain scores, and you give them good patient satisfaction by using these techniques. So kind of just take-home points, and sorry for hurrying so much, but hopefully we can have some questions. But first and foremost, with any SI joint, primary or revision, make sure you're not swinging and missing, and that we eliminate all other diagnoses. Treat the hip first, because this is a huge contributor, which really has not been well reported. There's some Japanese literature out there that's starting to look at this more, but the hip should be fixed first, in my opinion, and then lower their pain score with the SI joint fusion surgery if they have facet issues. And if they don't do great and they want to go back and do more stuff in the back, then you can. But the SI joint recovery is typically way easier than, as you all know, than just doing multi-level spine surgery and fusions. Revisions do indeed help. Set realistic expectations up front, and meticulous planning and templating. So that was fast, but my emails are on the bottom. If there's ever any questions, I'm always happy to entertain these. I'll stop sharing at that point and open up the floor. Thank you for your attention.
Woody, that was awesome. And I commit to you one thing. Next time that you speak, and anticipate more invitations to spine conferences. This was outstanding. And it's so nice to see somebody other than Dr. Pauly talk about SI joints. And we love Dave, and he's a frequent visitor here. Next time that we meet in a conference, I will wear a suit for you and a tie. So no chip route pajamas. That was his standard work outfit. So really, really cool talk, amazing images, and very thoughtful and realistic, and no overemphasis, but also no underemphasis on the SI joint. 2 questions. Number 1, you kind of glossed over the physical exam thing, and this is the biggest crux of the matter. And with Chris Standard, years ago, we published something, how unreliable physical exams are. And we have the 5 exams. Most of us don't do all 5, to be honest. I have my own exam, but I've not published on that yet. What is your preferred physical exam finding as an experienced trauma surgeon? What kind of gets your antenna raised that this is SI joint pain?
We have we'll be publishing that shortly on YouTube, but so it is a standing PSI sulcus examination with the fingers in the PSI sulci to see if they have tenderness there. That is pretty convincing, right over the PSI, which you can usually feel. Then on the patient in the supine position, we just do a PSI sulcus or Fortin finger test in that position. I do the Faber examination next. Faber is almost useless. It's great when it's positive, but it's completely unreliable. My favorite test, which I've kind of coined the Mayo SI joint test, is combine a Faber with the PSI distraction or Fortin finger test. And when you combine those 2 together, you have 2 additive forces on the SI joint, and that will typically make them extremely painful. And what's interesting is that in 3-6 months post-op, that exam finding is dramatically improved. So that is a combo test of Faber and the PSI distraction at the same time. Then I do the standard Gainsland's test, drop the leg off the side of the table, and then I bring it up to do a sacral thrust, posting my finger on the PSIS and pushing down on the hip. And those 5 tests are my main exam maneuvers.
So I'll tell you my favorite exam test, and it's not published at all. And here I'll unroll it publicly. January 18th, 2023. It is the hop test. I have them stand on one leg, hop. I have them stand on the other leg, hop. If that reproduces the posterior sulcus, as you call it, and I'll adopt your name, that for me is my highlight. But I totally concur. We don't have a great test. For me, this is my provocation test. Now let's talk about fusion. So we've coined this term metallusion. So a lot of manufacturers kind of have marketed these metal bolts that get pushed across the SI joint 2, 3, or 4, sometimes, as you showed. And they claim that you don't need to have a fusion, that the metal voodoo surface blasting, windowing fenestration allows for a effective stabilization. What do you think of that metallusion concept?
You know, I like the concept. As I alluded to in my talk, I'm a big believer in a true fusion mask, because that's what we go for in every other area of the body. And when things don't work, what do you fall back upon? A pseudoarthrosis with the lack of healing bone. So again, we see it's this numerator-denominator concept. And the numerator I see are fails, which don't have a true fusion mask. But I know the denominator is pretty substantial, and there are patients where it does work on. And I really strive to get a durable fixation with fusion masks, because I know that those patients are going to have predictable long-term durable outcomes. Our revision for true fusion techniques for loosening is 0, and that's a big feather in the cap for true fusion techniques.
And do you rely on CTs or bone scans when you have a non-union or a stable occult fibrous metallusion situation? What tests do you get imaging-wise?
My standard workup for every primary and every revision is a CT scan with axial, coronal, sagittal, and coronal oblique reconstructions to look for halos, and they all get AP inlet, outlets, and flamingo views to look for anterior pelvic ring instability, which may be related to the failure. So. And everybody gets pre-scheduled for an injection. That is the standard workup, and I think necessary.
One last question from my partner, Dr. Oskuian, our chief of spine, but I'll thank you again for these great insights. Ron.
Hey, Woody, that was a great presentation, and I really enjoyed kind of seeing the evolution of what you're doing, just in terms of, I think going more minimally invasive. I've always used a metrics retractor myself. And I've had other spine surgeons tell me I'm crazy. So I'm glad to see that you're doing the same technique, because I think it provides you a nice, corridor to get in without going through all the muscles. And then I love the plate that you put on and how it compresses the SI joint. I've never seen that before, and I think that's really genius, because we have a hard time, when we do it. Obviously, we don't do the trauma approaches you do from the lateral, but from inside, it's really difficult to compress and try to get the SI joint. So I think it's ingenious that you're doing that. And then the third thing is that, what do you see yourself, and do you use navigation, and what do you see yourself in 5 years doing that's going to be different?
So there are 3 ways to put this implant in. The way that I'm taught and trained out there at Harborview with Chip and the group is to do it all percutaneously with inlet and outlet views only. That is hard to master if that's not what you do on a daily basis. And so option 2, what we've done, I do it on deformity cases where it's tough to see, is we do the guide wire, getting the critical part, that pin all the way in the vertebral body between 5 and 1 with navigation. And then we use like the SurTrack system and put the pin in there perfectly. Then we bring in fluoro and do the rest in an outlet view, because that's the critical part's done for safety. Option 3, which if you guys know Arjun Sebastian, one of my partners here, we're going to do a guide wire only technique, which is going to be 100% navigated. And that's kind of an evolution now. So to where I'm going to go in the next couple of years, it's going to be much more kind of navigation and then a guide wireless system.
Which approach is that? Is that a lateral still, or from like an oblique?
Yep, these patients are prone and a lateral approach, and then it's all like in all my templates, the trajectory of the implant is perpendicular to the SI joint axis. And so you're compressing this in its native alignment versus creating a shear effect where you're not going against the SI joint in its native orientation. So I think that's another critical point.
Yeah. Do you think it's the plate that pushes the whole crest against the SI joint?
Yep,
Because
I
when
do.
you just use a standard, it doesn't compress it as much.
Right, because what happens, you're probably getting a little bit of ilial deformation as you're doing your compression because your fusion zone is in the middle of the SI joint.
Mhm.
And you're not necessarily confusing the fusion zone in itself, but what you're doing is taking the entire ilium and compressing it up against the sacrum to create a much more stable environment, which is what we need for arthrodesis or fracture healing, you name it, bone healing needs compression and stability.
Cool.
So
Thank you.
Woody, this was, I want to reiterate the one time, outstanding. And sorry to tell you that, but we'll have to invite you again to other meetings for our hands-on courses. There's so much wealth of detail and practical information here that you shared with us. So thank you so much on behalf of all of us.
Yeah.
And please say hi to our friends, Dr. Sebastian, Nasser, and all the others. It's a great group you have there. I'm so glad to see your trauma perspective. Take care and be well. Good to see you.
Thank you, everyone. Bye-bye.